How you guys doing today? It's Anthony Gangi. Welcome to another episode of Tier Talk. Today I thought we could dive into working with medical. It's such an important topic, especially now with what we have going on, that I think there are some areas that we could still re-explore, maybe cover some new areas, definitely partnerships with mental health, so things outside of custody, so maybe other departments that medical has to work with. And of course, when it comes to medical, I got my people, Connie Alleyne. Connie Alleyne, how you doing today?
Hi, good morning. I am doing well. My name is Connie Alleyne. I am the founder and president of the Civilian Corrections Academy. I absolutely enjoy this work and I look forward to our discussion today.
Hey, Connie, let's not forget, Connie, you have other stuff that you're also doing besides the Civilians Correction Academy, which is phenomenal, by the way, but you also have some podcasts. Let's get the podcast out there.
Absolutely. All right. So I have The Fly Behind the Wall. We are in season 2, episode 3 dropped on Monday. Episode 4 comes out this Monday at noon. And we have conversations with Connie that's directly on my website, which are questions that people are asking me. And so instead of answering those questions in a vacuum, I'm just answering those questions on the website.
And Connie, I'm sorry for not being in any of those episodes. My schedule was busy. So I do apologize. Hey, so, and guys, if you, a little sarcasm there, I don't think I've been invited. So we'll have to work on that next time. Hey, but real quick, again, we really are going to explore some different topics with medical today. I really want to also get to know you, Connie, in this episode. You know, we always ask people what generally motivates people to come into corrections. I think I want to ask you first. You know, what motivates you. So when we come back from our sponsors, let's get to know you, why you chose to get into the medical profession, why is it so important for you? And then we'll cross into some of the daily grind that can be more generalized. But I have a feeling, though, with your experience, with your knowledge, I think what you say, even if it's personal to you, is still going to be able to be general, because I think that you are a good definition of what I would like to work next to as a correctional professional. Now, guys, if you haven't, the show Chair Talk City, brave men and women that work in corrections. So please subscribe, interact, engage, comment, hit that bell. That bell is going to notify you every time I post a video. We're going to go to our sponsors. Then when we come back, we'll get to meet Connie a little bit more, and then we're going to explore working with medical. Stand by.
I wanted to attend a university that had an intelligence program. I wanted to look at problems different. I wanted to increase my critical thinking abilities. AMU offered those avenues to expand. Obtaining your degree as an adult, you're actually paying yourself and investing in yourself. You can't put a dollar on it. It's priceless. It's something that can never be taken away from you.
American Military University. Learn from the leader.
Guys, inmate manipulation is a course that is highly needed. It's the process that's so slow moving and subtle that you don't realize it's happening. When inmates choose to manipulate, they manipulate our need to react. Situational awareness and insight is going to save your career. It's going to save you from doing foolish things. Listen to your gut. So the more insight we have, the more we can recognize what isn't so overt, and we can correct our behavior before we fall into a trap that we can't get out of. If you allow an inmate to pull you out of your prescribed role, you are opening up a door for a host of problems.
Inmate manipulation, the psychology behind inmate manipulation. Available now. Link in description. All right, and we are back. Hey, Connie, this is going to be a fun topic because you're in your expertise, you're in your wheelhouse, and I know this is something you're very passionate about, but I don't think I've ever asked you what really motivated you to choose to become not just a nurse, but a correctional nurse.
All right. So I started out my career, like early on in the career, before I even got into corrections, I was an emergency medical technician. I think seeing firsthand the way, I learned so much going through the training that I really did want to be involved in medical. I just was never sure what aspect of medical. And fast forward a few years, I lose my grandmother. She ends up passing away, but in the time that she was home, we cared for her at home. She wasn't in a nursing home. And so understanding, how to do wound care and understanding, what diabetic treatment looks like, and advocating for all these different medical services that we just didn't know existed. Like, I think that kind of brought me into the medical space. And then I started working in a nursing home. Turned out to be a little bit much, just because it was like every time one of the patients would pass away, it was almost like losing my grandmother again. And so I figured there was some other way that I could be in the medical field. So I am not a nurse, and I want people to know that. I went to school, I did my master's in public health. And so working in the prison system was where I thought I could affect change from a public health perspective. How do you get close enough to populations and be able to sort of affect change through policy? And so that was really my biggest thing. And so when I did get into corrections, it was great because I got to learn more about different populations. So in prison, you've got the addiction, you've got the mental health, you've got the medical, you've got the homeless, you've got the domestic violence. You have all these populations sort of all in one place. And so that was my motivation, that I could be in a place and really learn how to care for a population that really, there was just so much that was there, from a research perspective. If you want to understand things about specific populations, that's a great place to research. You have access, and you can give yourself sort of the insights that you need based on like really learning the intricate details of the lives of the population. So that was really my drive for being there. And then once I got there and I realized like, wow, like, so I could actually make some changes. I could actually make a difference. I could advocate. I could do all these great things that I got an opportunity to do while there. Like my profession, my career just started to evolve into this space of advocacy, which I didn't initially think that that's what I was there for. But I would have employees coming to me, and then I became the actual union delegate, which I was like, you want me to like talk on your behalf? It's like other people could see things in me that probably I didn't see in myself. And so as life and work evolved, like I got into this space where I was managing, I was advocating, I could see sort of all of the issues and the impact to the offender population. I could clearly understand the psychosocial elements. And then with the employees, I just understood what it meant and what it felt like being on the front line. What did it feel like to not have your supervisor's support? What did it feel like to, want to try to do your best, but not have the tools to be most effective?
And obviously it's easy to tell you have a drive to help. And I think you were able to find a profession that kind of balances the want with the need. And I've actually discussed that in our motivational video, but I don't know if it's really a sidebar, but I got to ask you, because we have a lot of civilians that come into this profession with that want to help. How do you balance the want to help with making sure you're also not being taken advantage of?
So it's really taking the time to understand the intricacies of the story. Like, I feel like all the offenders have a story, and there's that piece within you where there's that discernment. You have to be able to discern that someone's taking you for a ride versus this person has presented me with consistent facts and details that would help me to understand where they're truly coming from. I know I have been in a space where I'd actually call people out like, hey, you trying to run game on me today? And, I think I'd gotten more respect from the population by doing that, as opposed to kind of just going with the flow. I mean, you have your obligations to work. You have, here are the expectations that the job has of you. And sometimes you just have to follow through, right? But other times it really is kind of nipping it in the bud and letting them know like you aren't being taken for a ride.
Right. I wanted to get that out there because I just want to make sure we didn't ignore that topic. I think a lot of times the people that enter correction, a little bit different than the custody perspective, but still some in custody that do choose to enter the profession to be that role model, to provide some type of mentorship. Believe it or not, we do have that on the custody side, but definitely I would like to think that those that enter the civilian side, the medical side, the mental health side, the program side, the religious chaplaincy side, education, there's a need that drives them to want to help. And I just want to make sure to not let that need to help override what we need to get done, policy and procedure, because inmates will be able to take a notice of that, and they'll be able to notice that you're motivated by the need to help, and that's actually making you extremely vulnerable to manipulation. But I like what you also mentioned, though. Your need to help still gets fulfilled within the guidelines of what needs to be done. So it's not like that the guidelines don't provide me enough. The guideline provides you, yes, enough to protect yourself from being manipulated. And I just wanted to get that out there. I know that in your corrections academy, your civilians correction academy, I know that's a big part of what you focus on, how to balance the want or need to help and making sure that you yourself are not being taken advantage of. Now, if we talk about the layout of corrections, the layout of the prisons, the jails, obviously medical has to work with many different departments. We know that. What are some of the departments that you work hand in hand with outside of custody that you got to have that relationship with?
We work collaboratively with reentry. We work with programs. We work with the counselors. We work specifically with mental health, with dental. We work with literally everyone, because if someone is medically unstable, they may not be able to participate in other areas of the compound. And so we communicate usually with anyone and everyone who needs to have the information to understand why an offender is or is not participating in a group. Many groups that are required for release, we try to make sure if there's any medical issue that might be outstanding, or that there's anything that any treatment they may need to be in, we try to make sure that we communicate that with groups as well. And quite frankly, if there is some sort of medical issue that we need to make sure so like if the reentry is setting up this offender to go into a program, but they have a prevailing medical issue that hasn't been stabilized, we usually work with them to also find that continuity of care in the community, so that it's part of that reentry initiative. It's part of that reentry plan.
Right now, not to minimize the other departments, obviously everyone has tremendous value in what they do and what they have to accomplish, but I know a big bulk of your working relationship definitely has to be with custody. You have to have that working relationship with custody. So even me, when I talk to my people, I always make sure that custody is aware of how important medical is, and vice versa. I would like to think that medical realizes how important custody is. And I was wondering if there are moments where that, maybe you could share in which custody was extremely beneficial to you, but also vice versa, where, you were beneficial to custody.
Absolutely. So the facilities that I've worked in have been accredited. And so with an accreditation, there are certain guidelines by which we have to follow in order to, comply with the inmate requests, to comply with just in general communications, or even just being in compliance with how the facility should be kept, like how the mental health or medical unit should be kept, what the temperature of the refrigerator or the freezer is. And we've had to work, so custody isn't necessarily involved in that type of stuff, but if in fact we need something, we've been able to go to custody and say, hey, listen, we're going back for reaccreditation. We have the survey coming up at this point. Can we make sure there's no mold in the showers? Can we make sure that there's no, like the refrigerator is at the right temperature? And custody will work with us to get all of the right people in to make that happen. Even if it's just needing the right cleaning supplies to make sure that the showers are clean. Like it's always a collaborative effort. And then it's great when you have custody who actually will call us and say, hey, listen, we got this guy or this woman down here in the unit. Could you send someone over to check on them? Because, they're saying they're having an issue with walking, or they're saying they're having an issue with whatever. And we'd go down with a wheelchair. We'd go down with, our emergency kit or the emergency bag to make sure that we are able to help in any way that we can.
I know from the administrative level, you definitely see the partnership, especially when you have those audits that come in, and, people don't realize that, at least from the administrative level, a failure at any level is a failure for the facility. So, it's great when we have an audit. People are like, well, it's a medical audit. I know, but I still need you here, because in the end, medical, yes, they're responsible, but there's a partnership here. They're making sure that we're able to supply them what they need so we can pass the audit. And I know for a fact that when you're up top and you start seeing like where the failures are, it's funny because if we worked in an isolated fashion, if administration sometimes administration, not at really good working facilities, but at facilities where a lot of people think that their mission is different than everybody else's mission, you'll see that the facility is not meant to last very long. That facility is going to fail on so many accounts. I realize that when you want to see the good partnership and really how a facility runs, the results of those audits do show a good partnership, because when it's all said and done, medical will come back and, hey, thank you, custody, thank you, mental health, and it's great. So a successful audit will show you the great partnership that we have between the different departments, and on the adverse, a failure will show you, man, this isn't about people not wanting to do their job. They're just doing it isolated. They're doing it without no sharing of resources.
Yeah, audits are particularly stressful, especially if there's this expectation that there's collaboration, right? So for example, if you have someone who's on observation in mental health, right, and you've got the officer outside, but you've got, the nursing team who has to go in and actually physically check to make sure this person is stable, to do vitals, to do medication, like that collaboration is essential, because that officer is making sure that nurse is safe when she goes into that unit, when she goes into that cell, if she has to. And so I think what we find during the audit process is where there could be some gaps in spaces where we're not collaborating. And so it's particularly important that we actually take action when we get those audit results, so that we are addressing those gaps or those vulnerabilities that maybe we didn't identify, because we sometimes do work in a silo, right? This is what I got to take care of. Cussie's making sure they're signing in the book. I walked on the unit. I didn't sign in the book. Does that mean I wasn't there? No, but it's a reminder when we go through the audit that everyone who comes in a unit needs to sign on the book, right? You have to be able to show that you were there and what you were there for and what inmates you saw. I think it's these little things that can get overlooked because they're such a part of the routine of the day. And so as we work more collaboratively, it's not too much for the officer to be like, hey, Connie, you didn't sign in. Like, I'm like, holy crap, because I am kind of just focused. This is what I'm here to do. And I may not remember that I need to sign in, but I think it is in the collaboration and us both understanding how important the logbook is, right?
Yeah, I actually definitely know you see it when you got to count your needles, let's say, or things that have a direct relationship to safety and security, where you get to at least see, I hope it's not a forced interaction, but an interaction that has to happen. And you kind of get to have that little dialogue between, at that point there, custody and medical, and you see that good working relationship, because at that point, if there's a missing needle, custody and medical are both going to be held responsible. So I don't know if it's out of survival mode, but I would like to think that also brings us together. So yes, I know I'm talking about the negative side of it all, where if something's missing, how we both going to scramble, but in the end, we're both sharing each other's responsibilities. So there's a positive in that as well. There's an appreciation, because I'm looking at you like, hey, if you don't have that needle, that's on me. And you're looking at saying, well, it shows that there's a great partnership. And I like the fact that, if there's a concern, you see everybody at the table trying to settle it where each person has value, their opinions have value, and then we don't look at everything isolated, like it's my department, it's all about my department. No, you don't. Administration, their main job is to facilitate the connection between the different departments, so we don't have a selfish department. We have to try to keep things fair, but it's great to be able to sit back and see it just happening automatically without you having to get involved.
Yeah, and it shifts from any one person having to take ownership. We take ownership for this thing, whether it's the sharps, whether it's the mouth checks after, like on Medline, like whatever it is, we take ownership for what has happened. Like nursing or medical is going to do what they have to do on the front end, and then I think we should be able to count on custody to kind of just have our backs. Like, oh, if I'm sure I did the mouth check, but did he cheek it and I just didn't see it, but then custody saw it and it was addressed? Like, I feel like that's where we do see a good partnership.
Right. Now, I want to talk about your FTE, or in some cases, full-time employees, or just what you need to have available staffing. So first off, a lot of us may not know exactly what these positions are. Now, if you're from medical, obviously you have an understanding, but don't forget we have a broader audience here that may not understand the specific job functions of each title, and actually may expect more from a title that's not able to have, or able to have the ability to do that function. So in order for you to, let's say, to have a staff that's able to cover the needs, we're not going to talk about numbers, just, cover the needs. Who do you, at bare minimum, who do you need present, starting from the, I guess it would be the lowest position, like a rank structure, no different, and then all the way to the highest position available on a daily basis?
So we need a phlebotomist on a daily basis, because there's always blood levels that need to be checked. There's always labs that need to be done. We need to have at least an LPN who can administer medication. And quite frankly, depending on the size of the facility, you may need way more than just one. Most facilities do need more than one. You also need your RN. Your RN can do all kinds of treatments at different levels. Many times they are certified to do specialty treatments, like if you have dialysis going on in your facility, or if you have, we've had people come in with like rare blood diseases. I mean, the type of things that we've seen come in, RNs are the ones who can do that. Now, we also have APRNs who are in there, and like, they're really great to have, because if you don't necessarily have a physician, at least the APRN can write a prescription for medication if in fact you have someone who needs medication and there isn't a physician on site available. We have the nursing supervisors who essentially keep all of that coordinated. They make sure that the nursing team have whatever it is that they need throughout the day. As little fires come up, instead of the nurses being pulled away from whatever the assigned task is for the day, you have the nursing supervisor who might come in to handle that fire for the day, or the fires that come up within the day. We also try to make sure that there is a physician on board, because there are these situations that nurses encounter that really need an elevated level of medical oversight or medical intervention. We try to make sure that on the mental health side that we have a psychiatrist available, a psychologist available, and we have social workers available. Social workers are running the groups throughout the day. They're the ones who are trying to make sure that, they're monitoring their caseloads. If there's anything happening with an offender on the mental health side of their treatment or of their care, the social workers are usually the first ones who are stepping into action and making sure that that inmate, like, they facilitate if the offender needs to see the psychiatrist, if he's complaining about their medication. Like, they're the ones who are like the advocate, but they're also the ones who are providing treatment and intervention along the way. So those are mostly like our bare minimum. Now, granted, working in a female facility, we've had an OBGYN on staff who can help support the feminine needs, as well as care for women who are pregnant. We've also brought in, I want to say, APRNs who are specifically women's health APRNs, so that if there isn't a OBGYN on staff for the day, that you at least have a women's health APRN available who can still facilitate treatment and care at their appropriate levels. So, there are different tasks or allowances within the scope of a license, but at a minimum, that's what we need.
Right. And when you say social workers, you mean clinical social workers, correct?
Correct. So we do have clinical social workers. I know that in some facilities, initially it was okay to just be a social worker. Then it was a requirement imposed that you had to have a license. So now we have licensed clinical social workers who provide treatment to the population.
I wanted to make sure I remember there were changes to that. I also find at the higher level, administration deals a lot with the nurse managers as opposed to the doctors. And a lot of people think that the doctors are the ones that are running things. And I actually think that it's more on the nurse manager side. But with that said, I know you have, now I see you're ready to discuss this because I see that smile. But I also want to ask, do the nurse managers have some type of level of authority over the doctors?
So because the nurse managers are the ones that are coordinating everything, it's not that they have authority over, but they're directing the traffic. They're making sure that this doctor's clinic is being taken care of, that the nurse is organized to support in that doctor's clinic to make sure like the flow happens. Because sometimes, doctors may want to focus in on a particular treatment modality or something, and the nurses just tend to know what are the other options available, right? Like you want to be very strategic with how we utilize our resources because we don't have a lot of it. And unfortunately, many of the doctors, because we don't have a lot, their caseloads for the day can be very huge. Their call down list for that day. And so the nurse really just does her best to keep that flow going within that particular clinic. The nurse managers, I think, are really just good at solving those problems and removing any bottlenecks in the system.
And how important is the communication between the nurse managers and the doctors?
It's absolutely important. I mean, so if in fact, so the nurse managers usually know when an offender has been down there 100 times, right? And when something else is going on, the doctors don't really get that involved. The doctors are looking at what is the issue at hand today. I want to address that issue so we can move on. Whereas the nurses usually have a more holistic picture of the offender, and they've gotten to know these offenders as they funnel in and out the clinic. And they're the ones who can kind of say, hey, doc, this guy was just here yesterday. This is what was done. And, the doctor can then adjust his or her approach in the moment so that offender isn't bottlenecking the system or holding up productivity for the day. So it is really critical that they have great communication.
When I started doing Tier Talk, part of my mission was to make sure that the public recognized the hard work we do, yes. But then I started realizing that we really have to recognize it in ourselves, because I really felt that a lot of people that had joined into corrections saw it as, can't get this job, I can't get that job, so I might as well just settle. And to me, I thought that was always frustrating because of my belief in this profession. And when I tried to get the public to recognize it, I said, well, I'm doing it backwards. I got to get us to recognize it in themselves. I can't have them see corrections as being correctional is something they settled into. No, this is a noble profession. Stand up, recognize it for what it is, and then go ahead and be proud, chest out high. Do you think that there's a lot of nurses that may have fell into correctional nursing because maybe they were forced to, or they feel that they're settling, and then you as a manager kind of have to remind them of how important this position is?
So I feel like there are nurses who really want to make a difference. There are nurses who understand how sick the population is behind the wall, and who know that the skills that they bring could make a difference in the system. That I know for a fact. And many of those nurses have come in with their specialties, and they know, like, okay, if I come in, here's what I can do. There's also just the benefits, right? So you have the benefit in knowing that, like, as a nurse, if there's something I want to go to the next level in my career, I know that corrections in this space, not only am I going to be able to hone in my skills, but in this space, I'll also be able to get the support in going to school and elevating, and probably even the position I'm looking for, I could probably get that position in this same space that I'm in. So I think there's different reasons and different levels of involvement. But what I've found is that many of the nurses, they are really like wanting to make a difference, and they can actually see their work because, you know, we've got this captive audience. If they've implemented any treatment, they can actually monitor that treatment and see how the offender is progressing. You can see the growth. You can see the healing, you know?
Now, when you opened up your civilian correction academy, you noticed that there was a gap, correct? You noticed that, okay, so the civilians haven't been getting this, and I want to go ahead and make sure they get that. So when you, let's say you're coming from the streets, and let's say you're either going to get ready to work as a correctional nurse full-time or maybe per diem, what are some of the things that are not the same that immediately you have to make sure that, okay, I know you've done this on the outside, but on the inside, we're going to do this a little bit differently?
So the building of rapport with the population is very different. So you think of bedside manner as a nurse in the outside world as opposed to what your bedside manner would be in the facility, right? Like, so you're still expected to be professional. You're still expected to provide the highest level of care available to the offender. But the way in which you would engage with the offender would be very different than the way you would engage with your patients on the outside. The things that you might get requested or from your patients on the outside are not things that you would possibly comply with on the inside. Like the offender asks you for extra bacitration ointment. Like you would not give that to the offender, although on the outside, it would be fairly harmless if your patient said, can you give me some bacitration for me to take care of this wound on my own? That's just an example.
Right. And I think obviously I agree, because the problem is also on another note is that once you set that precedence, then someone else is going to come in and say, can I get an extra Tylenol? And it's like, no, well, you gave such and such extra vaceration, whatever it was there. You know what I mean? Sorry. So again, it sets the precedence where now you're starting to break away from that being firm, fair. And you're right, man. It takes that one little thing, which you may only be seen as little, but turns out to be something big within this profession. Also, I was going to ask you also, what about your relationships with other departments and the resources that you have inside the correctional center? Are they slightly different than the resources that you will find on the outside? And what I mean by that is also, are your needs met more immediately inside a correctional facility as opposed to on the streets? Because I'll give you an example. Just to, if I'm, let's say this is my community, right? So consider me, you know, and, hey, in Jersey we are police officers, right? So if I have an inmate with a medical, so I can get medical right away. I can get mental health right away. I can get them in program right away. You know, so I have immediate resources that I think that police could take a little longer to get to. I'm wondering if that is maybe the same for you, where if you need some immediate resources, they're quicker for you to get, or in some cases you just can't get them at all.
So it depends on what the need is, right? So many facilities are set up to have partnerships with outside providers so that in the event there is some sort of special circumstance. For example, if we had a really high risk pregnancy, even though we have an OBGYN and we have the medical APRN on site or the women's health APRN on site, our reality is that we can call the local hospital and say, hey, listen, we have this high risk person here. Can we get them in for an appointment today? Usually they will be very much accommodating. Now, there are other times where we are challenged to get resources because we are competing for slots. We're competing for appointment slots in the community. So if there's some other need that comes up, sometimes there may be a slight delay, but usually I know as administrator, I could pick up the phone, I could call, you know, a specialist out in the community and say, hey, listen, I've got this case that came in, we're really not sure how to handle it, and we need some support. They'll say, okay, can you make an arrangement to get them there? Now, I think the really cool thing about having a good relationship with custody is that even if that person wasn't set up for transportation for that day, if we can get an emergency slot and I'm able to contact custody and say, hey, listen, we've got this situation going on. We're trying to get this person out for an emergency transportation. Like usually custody will accommodate and get that person out. Sometimes, we have to go back and forth about, the overtime it might cause because that person wasn't slotted to do that transport. Like those little, I think, operational challenges that we come across. But for the most part, we're able to work together and resolve those issues quite quickly.
First off, I agree to that. I think that if medical has a good working relationship with maybe the head of custody or the operations side of it or the shift commander, we're able to facilitate things a lot quicker. And then if not, administration has to obviously get involved. But most of the time when you have inmates coming out or have to go on a trip, administration can be made aware anyway, and they're going to make sure it happens because obviously medical liability, don't want to tell medical no when you have an emergent situation happening. And sometimes, as I said, maybe some people don't see the bigger picture that way. Like I don't have the overtime, yeah, but it's going to cost a lot more later. Trust and believe if this goes into a lawsuit, it's going to cost a lot more later. One of the other things I wanted to ask you is a lot of people actually don't believe that the medical that's there to help the inmates can also help staff. A lot of people are under the impression that the medical that is located in these correctional facilities, if a code happens with any staff member, that the medical there can't get involved, that it automatically needs outside help because some nurses may say, well, we're not here for the staff, and they're not saying because they don't want to help, but they're also afraid that there's a liability if they do something wrong and the staff member decides to do a lawsuit. Are you guys able to help staff if it's emergent?
So it has been my experience that we're able to help staff. I mean, quite frankly, we are first responders as medical, and if anything, I would imagine people are more willing to go and respond because it is a staff person. Now, yes, I've been in many discussions where we've talked about the liability that may arise if someone has taken an incorrect action during that time. When you're caring for an offender, you're legally covered by your institution. When you're caring for an employee, I think there's some gray area there, and some people just may not feel comfortable doing that. But the reality is that, like, a doctor is a doctor, right? And so even if you're being a good Samaritan, there are rules and laws that cover the good Samaritan, right? And I think in these situations, I mean, there are codes. Isn't it like a code blue is specific to an employee, right? So like the fact that there's a code established means that there's some process in place that supports the response to care for an employee who's in some sort of distress.
Okay, so like, I don't know how it is for most places, but I know for places that I'm familiar with, they keep the medical code the same because they still want the response to be the same. So basically, if, I don't know, let's say it's a code 12, who knows? I don't want to put out anything too specific. But a code 12 would mean that there is a medical emergency. They're not going to denote if it's a inmate or if it's a staff member because they're going to want that same emergent response, that same urgency. And they feel that if you separate it and say, well, code 12 is for staff and a code 13 is for an inmate, some people will see it as, well, I guess you separate the code because you're pushing that there's a less urgent need for the inmate to receive the attention. Same thing with codes that deal with emergent situations where staff needs assistance. You would like to think some places do, some places don't. That you have one code that says, okay, this is a staff that has a problem, and then another code that says, okay, these are just inmates on inmates. The problem is if you separate it, if it ever travels down to the liability side, someone's going to ask you, especially if there's negligence at any end, why is there a difference in codes? Why do you got to denote the difference of a staff member being involved whose life at that point from the outside is going to be seen as just as valuable as an inmate that could have gotten injured? So what we try to do is we try to keep the codes kind of one. So we keep that same urgency thing. And then when we run, if your mindset is, if your mindset is, I'm going to run to staff more than I run the inmates. But by the way, our staff, obviously, that, Connie, our staff's going to go at it regardless because we're first responders. A life's a life. It's our community. Then this kind of neutralizes that and says you don't know. But I will say sometimes, because it all matters on also the person calling the code. So I'll give you an example. not that we get caught up in the daily routine, but there are some inmates that, still going through drug issues, drug concerns, and they could be overdose and stuff that, again, a life's a life, don't get me wrong, but kind of gets caught up in the daily routine of what we do, and we don't mean to be any less meaningful or life's a life, but again, you're dealing with it every day. Staff member that goes down may not be an everyday thing. Staff member that has their heart may not be an everyday thing. So staff sometimes may be saying, a little bit more nervous about it because, again, it's not something that happens every day. And you may be able to hear that slight urgency over the radio when the person calls it out. Or they might even go as far and saying, because they're nervous, hey, officer such and such is down. Because, again, it's not something they deal with every day. Doesn't mean that it's less urgent. Life's, they all have equal value. I understand that. And obviously, when we create a venue like that, that is the perspective that we have to have that comes across. But in the end, I think because, like you mentioned, the staff is going to be a little bit more rare. And I think because it's not something we're familiar with, we tend to have a heightened urgency to it. And I mean, all situations could be scary, but when you're working with your peer and you turn around and they're on the floor, that's a very unique situation. It's very tough to deal with. Very tough to deal with.
I think one of the other things too is that in responding to those codes, I've actually seen the nursing supervisor actually kneel down to the staff person and say, do you have any medical issues we should be aware of? Right. And it's like doing a quick assessment, and not so that to violate anyone's privacy, but if there's something else that we should be looking at to make sure you're stable by the time the ambulance comes, like they're doing their best to do that and still respecting your privacy. And I think sometimes the challenge is that, you don't necessarily in the workplace know all of the medical challenges people may be facing outside of the job. And so I think that's where some of the hesitation comes in, that you do need to be able to do a quick assessment of what's going on with that staff person who's gone down.
Hey, Connie, I want to talk about higher level management, because I know you are a medical administrator, which means that obviously not only do you have to oversee your whole area, but also you have a lot of communication that you have to deal with on the other side from working directly with the administration of the facility. So, what would you recommend to kind of create that good partnership and making sure that your needs and the people that you represent needs are being met by the administrative side of things from the correctional facility end?
So as a health services administrator, there is no, the responsibilities are just very vast. So within my system, what fell under my wheelhouse was medical, mental health, dental, and discharge planning or reentry, as well as MAT. And so with that being said, the administrator has to have relationships with just about everyone. We worked closely with the school, working with the principal of the school to make sure that the offenders were getting medication early enough in the morning to be able to get to school. We worked closely with the kitchen staff to make sure the special diets were being followed based on what the doctors were prescribing. We worked closely with custody. I've sat through so many investigations, reviewing security tapes. The things that I've had to sort of deal with in the administration perspective or the administrative perspective is far beyond, I think, some of what people think the administrator does. And then on top of that, it is this level of accountability to your central office. So here are all the things going on in your facility. Here's the communications you've had with custody to make sure that internally we're aligned. And now you've got to take all of this information and sort of bringing up your chain through the central office folks, making sure that they understand and trying to fill the gap where there's some disconnection because they don't necessarily always understand sort of the operational challenges that are faced when they give us a directive or something to follow through. So just think medical, right? So this is your nurses, your phlebotomists, your whoever that falls into medical. Dental is our dentist, a dental assistant. Mental health is a psychologist, a psychiatrist, and you have the social workers, the clinical social workers. And it's understanding what are the procedures with medical? What do you do when you're dealing with a mentally ill patient? What do you do when you go into the mental observation unit? Familiarize yourself with the psychotropic meds. Familiarize yourself with the DSM-4. Understanding how you fit into the clinical team when we have those interdisciplinary team meetings, and doing that for the medical and mental health side. So the expectations of what the administrator knows and can manage is really very wide.
You know, one thing, I think we can come on a close after we answer this. One thing you never go in a little bit further is you always mention this, and I always forget. You were a union rep for your medical personnel. So obviously there are a lot of needs that you felt were not being met. So what are some of the things that you feel as a union rep you were able to implement some changes, maybe some concerns that you felt weren't being met by either your department heads or even just a working relationship with the prison?
So I served as a union rep on the discharge planning side of the house. And so part of that challenge is, one, the expectation for you to manage these huge caseloads. That was something that we had to advocate for, because simply you couldn't be effective. If you wanted us to check a box and just say, yes, I saw the inmate, that's one thing. But if you really want us to establish a plan for this particular offender so that he doesn't go out or she doesn't go out and recidivate, then it takes us time to actually build that plan, to get buy-in from the offender and know that that person is going to be compliant with that plan once we step out. So one, managing the caseloads. Two, having the appropriate amount of planners in the system. When you work in a system that has 19,000 offenders, having 2 or 3 discharge planners, there can't be an expectation that we're going to be effective. It just doesn't work out that way, especially when you start to deal with the intricacies of each individual case. You know, some people, yeah, it could be straightforward and they're going to comply, but other people, they have a substance abuse component. They have a mental health component. On top of that, you add a medical component. And so creating a discharge plan that includes housing, that includes some sort of Medicaid or Medicare or some sort of medical benefit so that they can actually transition into care once they get out, it really creates a lot. And so I think for me, it was advocating for wellness. It was raising awareness that, you know, the job is stressful. And also too, it's kind of one of those roles where, you know, people don't know exactly what it takes in order to make the transition successful. And so it's easy to minimize, like, oh yeah, you're the discharge planner, right? Not understanding that you've got to take so many pieces of the puzzle to try to put it together into a nice plan that's going to be received well by the community-based organization that you're trying to connect this offender with.
So did you find that most of your concerns as a union rep may have been departmental as opposed to maybe concerns with the prison administration?
So I think it's a combination. It probably was more departmental, but I think, you know, from the prison administration perspective, it's knowing that you have the support, right? It's knowing that if you're out there trying to get programming, because at a higher level, the prison administration has to establish certain partnerships in the community that makes it easier for you to put together these plans. And if those partnerships aren't established, as the discharge planner, you're starting from scratch. You're trying to build credibility. You're trying to build that partnership with this random person that you just called at a community-based organization. But when we've already at a broader level established a partnership and there's this understanding that you're going to accept the people that we're going to send, here's what we send them with, and you're going to be okay with what we send them with, or let's negotiate. What is it that you need us to do prior to us transitioning this offender into your program, let's make sure all those things are in place before they go. So, I think it's a combination, but certainly most of it was dealing with internal departmental challenges.
Right. At least what I like about that is that means that at least you were able to communicate well with the prison side of things, and they were able to maybe meet your needs, or if not, maybe give a justification, which you guys actually understood. Either way, you got to have that partnership. Do you have anything you'd like to say in closing, Connie?
In closing, I would just like to say I absolutely enjoy these conversations where we can talk about the stuff that goes on behind the wall, where we could share our perspectives and really just put it out there, because there are some really challenging things. I think it's an environment that has its rewards, but there certainly are some challenges. And without the partnerships that we establish, without the collaboration, we simply can't achieve the mission.
Well said. Now, guys, I think it's great that we actually have these dialogues. I think that we don't really get a chance to explore them when we're working in the busy facility. So it's great to be able to have people willing to come on afterwards and discuss it, because, again, during the day you could be missing so much, but now we have a nice chance to kind of discuss it, maybe have a little coffee, and just really get into what needs to be discussed. And, again, that's how you solve issues. So hopefully when they get this information, there's a better understanding, which motivates people to want to work together, because, again, during this dialogue, we wanted to promote the appreciation of how we need each other as opposed to why we don't, because that's obviously not true. So as always, guys, don't forget, we have a Tier Talk podcast. It's available through Law Enforcement Today, but could be found on Spotify. Good information. And then we have the Facebook page. Follow us on the Facebook page. And then, Connie, real quick, besides the Civilians Correction Academy, if you guys get a chance, check out the website. Let's get a little promotion for those podcasts. Very good information there.
We have The Fly Behind the Wall, which is on all of your listening platforms. And we have Conversations with Connie, which is available on ConnieAlleyne.com.
Now, guys, if you have trouble finding that link, you could also Google it. But the moment you put Anthony Gangi in there, it will not show up, because Anthony Gangi was never in an episode. But that's not a problem. We'll discuss that at a later time. All right, as always, guys, the show is Tier Talk. Please stay safe.